Victoria will be interacting with some Kenyans about the expectations when it comes to health this election cycle. Stay tuned for that.
All right, welcome back to the Voters Hub in a slightly different set today, but the conversation still continues. Now, this past week, we commemorated World Health Day, and it gave us a chance to take stock of where we are when it comes to healthcare in this country. No doubt, the COVID-19 pandemic laid bare a lot of the gaps that exist in our healthcare system. Now, let me give you a few numbers before we start the conversation. According to WHO, only 20% of Kenyans have some sort of medical insurance, and most of them are under NHIF. In addition, a quarter of total spending on healthcare comes from out-of-pocket expenses. Kenya still has not met its target of 10% of the national budget going to health. So what does that mean when it comes to seeking and getting health in this country? And the three main pillars when it comes to accessibility, affordability, and quality is what we're talking about today. Let me introduce my guests really quickly. From my left, we have Dr. Nelly Bosire, an obstetrician and gynecologist. Thank you so much for joining us today. We also have Doris Kadhia, who is a youth advocate, Network for Adolescent Youth of Africa. And last but not least, Ezekiel Libamira, a throat cancer warrior, as he likes to call himself. Thank you all for joining me today. Let me begin with you, Dr. In terms of the gaps, immediate gaps that come to mind when you're thinking about accessing healthcare in this country, what would you say they are?
Well, we have to first of all count the positives. In as much as we've had a lot of challenges with devolving healthcare, it does have its positives, and we have to say that probably some of the counties that were regarded as the hardest to reach have actually massively improved access to healthcare. So I will use Mandera as the perfect example. At the point we're going into devolution, it had only 9 doctors. Now we're looking at about 50, of which at least 10 are specialists. That's drastic. So in terms of accessing healthcare, we're looking at facility. Where is the facility located? Number 2, once you get there, are the services available? And is the HR complement to be able to deliver the service available to you? So we have places where in terms of accessing the facility is not a problem, especially in the highly populous regions, Nairobi, Western Kenya, where facilities have been developed over several decades, both in public sector, faith-based organizations, and in the private sector. However, that hasn't necessarily translated into the actual meaning of access. We've had places where we have struggled with human resource. Yeah. And I think you have seen us as practitioners really complaining about having devolved the human resource complement. We do have to accept that it has happened, but then we do have to hold the national government to account when it comes to policy implementation with regard to observing the required human resource ratios as per population. That right there has been a thorn in all of our flesh. We've had issues of tribalism and nepotism encroaching such a sensitive sector, where now we have doctors not being employed, where they are being replaced by maybe more affordable cadres like clinical officers, without due regard for the fact that some of the services cannot be delivered, cannot be delegated, cannot be shared. So that has been, I think, our biggest issue. How many nurses are we actually employing relative to the population we have? Their counties, since they inherited health as a human resource, haven't grown their human resource capacity even by 10%. It's been almost 10 years. So in 10 years, where has the population gone? And what does that mean in terms of meeting the health worker to population ratios? So that has been a big deal. The second bit is access to services. And the worst challenge here is that a lot of our county managers, if I would call them our governors and the people who work for them, they actually seem to think that buying equipment and putting up buildings translates to service. I always say no one goes to the hospital to see the CT scan machine. They go to the hospital to see the doctor. The doctor just needs that CT scan machine to make better diagnosis. So even if you bought all these things, but you don't have the human resource to use them effectively on the population, then access is still a challenge. Some are broken down, some are not being serviced. We're just looking at it from the perspective of tendering because buying equipment means tenders, means people can make money.
Yeah.
And once it's been dumped in the institution, whether it's actually serving the purpose or not, has remained a challenge.
And on that, let me bring in Doris. You know, Dr. Ari has just kind of described a lot of the scenarios in many clinics across this country. You live in Nairobi. What is it like for you? You know, on a typical day, for instance, you fall sick and you have to go to the clinic. Walk me through that process and just some of the gaps you've noticed as a health seeker.
Thank you so much for that question. And one thing I think I will take in a perspective of being a young person, we're seeking services in institutions and in facilities whereby even the doctors themselves and the nurses who are there, they are not really kind of interested in offering the services to you. When it comes to their attitudes, when you go there as a young person, for example, maybe I'm going to seek even some contraceptives, and the nurses there and the doctors are like, why would you come to seek contraceptives? Like, I'm short, so maybe most people would even actually think you're too young to be using contraceptives. So you find that the attitudes of the nurses and the service providers rather who are there is not appealing to young people who are seeking services. And in many situations, you find that they will not even welcome you really well to get the service that you want. They will be there to judge you. They are just there to like, where kuja to, what is your problem? And there is no really that attachment. Like when you talk to someone, they are not ready to listen to you. So sometimes it's really very difficult even to explain yourself, and especially if you're seeking comprehensive services where you need the doctor to really listen to you and take you through a certain process. So I think it's really a big challenge and a huge challenge, especially for fellow young people, especially in matters of sexual reproductive health.
So it's not a safe space?
It's not a safe space at all. And I think it's really high time that we continue to fight for spaces where we get all facilities have youth-friendly services, such that everybody, young people, old women, old girls, everybody can be able to access services without the fear of being judged.
And Dr. Ari, I'll have you respond to that because I know you're passionate about those issues, but let me come to Ezekiel really quickly because I want to talk about cost. Over 10 years ago, you were diagnosed with throat cancer, and walk us through, because cancer is the big C. It's such an intimidating word when you think about it, because you're thinking about how much it's going to cost. And we say in this country, you know, many families are just a health bill away from poverty. And we know what it means, paying out of pocket when it comes to treating a disease like cancer. But what was your experience like when it comes to seeking treatment and the cost aspect especially?
Wow. Tough.
Yeah.
Just to add on to what you said, it's been 13 years since I was diagnosed with what they call, in a layman's language, throat cancer. And first of all, permit me just to add on to what she, as I share this. I remember the day the news was broken to me. It was March the 7th, 2009. And the doctor, first of all, he was devastated before he actually now shared with me the information with those scientific cancer names. And now, by that time, of course, I was hit. And I'm still thinking and thinking. I was not even thinking the cost. I was thinking about how long do I have to live?
Right.
I was thinking about my children. I was thinking, wow, are they going to be orphaned? So the first thing I did is the doctor is talking to me, and he's looking at me, and I was praying. And I told God, you said, owe no man anything except the gift of love. And I said, I owe Rubadiri 2 million. Don't take me before I pay. And I mentioned in my prayer, that's how I dealt with it at that time. Then I began to think of cost. Before I even go to the cost, I began thinking, are we going to go through surgery? Which I got scared of. Many people, the layman out there thinks if you try to operate cancer, you've interfered with it and you cause it to spread.
Right.
I thought about what I was going to face, people. Then the reality came, and I went out there, and now a friend, a very good friend, was broken, and he says, no, I will not allow you to go through this. Let me take you to another opinion, because they were thinking this guy is going to die. But now when I got to the other opinion, just 2 days later, he was worse, and he says, this tumor is 5 months old. Where have you been? And he says, we cannot do chemotherapy and radiotherapy alone. I had read about chemo and radio.
Right.
I didn't think in terms of the costs involved.
Right. Yeah.
And he says we have to do some surgery first before. Then he gives me the figure, which by today's standard, that figure would be, by today's standard, that would cost about 10 million.
Wow.
By today's standards. And I wasn't still disturbed. I think I was still thinking how to deal with this. And I thought, Dr. Ria, I said, let me seek another opinion. And I went for another opinion, and they said, no surgery. And I think my healing began there. I remember, wow, no surgery. Now it's a question of how do you start going for this chemo? The bill is about 10 million by today's standards. I didn't have a medical benefit, or I didn't have access to one. So by God's grace, I had friends who said, let's get together and help Zach. And they did a fundraising, and it was one challenge after another. We were raising money. Eventually, we did a fundraising just before starting the chemotherapy and radiotherapy. They had given me a number of chemos, was going to be about 6 normal chemos then, and 33 radiotherapy sessions. What we raised was about half of what was to be spent. As if insult comes to injury, what they say, when it rains, it pours. Outside the fundraising room in church, my vehicle got stolen.
Oh my.
The cost of what we raised, and I had to go through that. So, long short of it, I just had to walk through, and more than anything else, I had to apply my own positivity and faith and say, I trust God, I'm going to go through. So,
and let me bring Dr. Ari in here, because there is a new initiative or intervention in the country, UHC, which is supposed to remedy this. And it's now been implemented in most counties. Where do you see it actually plugging that gap? And is it, or should there be another solution?
I think maybe the question we should ask is the user. What do they think? As the person who is a beneficiary of UHC, are you feeling the effect? Because if you're not feeling the effect, then it means we are not on track. It's really that simple. How many Kenyans can say, because of UHC having been rolled out in my country 2 years ago, I've had the benefit of accessing at least basic health care without impoverishment? I have yet to meet one who will make that testimony. I think the only county that has successfully rolled out UHC to some degree would be Makueni County. And that is not the national initiative. That was the county initiative for UHC, which was rolled out way before the national one came through. So I think that we do not have UHC is not an option. It's our reality. My struggle with UHC is very simple, that the implementers refuse to face up to the first reality. Healthcare is damn expensive. And UHC is not poor medicine for poor people. That's my problem right there. Okay? I'm struggling with that, and I keep wondering, we're talking about policymakers and experts, why are we not seeing that? We're supposed to look at universal health coverage as what are the basic services that 100% of the population should access? And for those, how do we make them accessible, affordable, and high quality? Once we are able to achieve that, then we can step outside and look at the healthcare costs that are not routine. Cancer, for instance. We may have handled the preventive aspect at UHC level, but there has to be a kitty to address. So what? We tried to prevent it, now it's here. Then this person's costs are going to break the bank, and these people are not many. And let me just use an example of what's going on. In Makueni County, they said they will collect 500 shillings from every home and use that as a common kitty from which to draw for care. And it worked fantastic. But they realized that every time they had to deal with border riders who'd had accidents, the cost of buying the plates was breaking the bank. So what did they do? They set a separate kitty for that and said, we're going to put in $500,000. You're going to come, and if you need it, we'll draw from that and treat you so that you're well. You go back to your work and refund that over a given period of time. So if you spend 60,000, you have a year or two, and you can easily, slowly give back to serve the next person, or even you in another time, God forbid, should you need it. So we would have imagined that that is just a theory that should have applied through. Do we have common conditions that require coverage? Yes, we do. What do we do about the ones that are breaking the bank? Because the malaria, the pneumonia, those are things we can take care of. Things like chronic illnesses, diabetes, hypertension. If the patient is able to access proper care, then that patient doesn't have to progress to expensive to treat complications. So at the universal level, every one of these patients is able to access their hypertension medicine, their annual screening for their heart and kidney function and all that. In that package, it's affordable, it's manageable. So we are not looking at UHC the way it is supposed to be looked at. Every time the UHC conversation comes up, everybody's always thinking, oh, the doctors are running too much. Oh, we want to use community health workers instead of nurses. Yeah. And I will tell you, a very respected head of our African Medical Associations, the current president, made a speech just early this year in a UHC conference that was held in Mombasa, and he directly spoke to the president and said, let Kenya not fall into South Africa's problems, where if you are rich and you have a headache, you will be treated by a neurologist. Wow. But if you're poor and you have a brain tumor, you'll be treated by a community health worker. That's what we're trying to make the UHC in this country about. It doesn't work like that.
And I have to bring in Ezekiel and Doris as we wrap up, just to get your take, because we're going to an election this year. And this is the time where, ideally, the aspirants and politicians should be asking you, what do you want? And oftentimes it's the other way around. But if you were to vote today and thinking about health in your mind, what would be some key things you'd want to see come out of this election? I'll start with you, Doris, and finish with you, Ezekiel.
Well, that's a very good question. And maybe for me, first of all, I would add even the politicians to, first of all, even as they are selling their manifestos, let them give us the manifesto that has health involved in it. Because one thing, even the leaders that we elect as members of this country are the reasons as to why we either have a successful or a failed health system. So I would want them to include health in their manifestos, and I would also personally urge even the Kenyans to elect leaders who are thinking about the public and not just themselves. Right. Because I think that is one of the biggest problems that we have in our country, whereby the leaders just think about themselves. They don't think about the common mwananchi. So yeah, I think it's high time that we think as Kenyans, it's high time that we think as members of this public, that whatever we decide as we are electing leaders, we would want to have a system, a health system that is really fab and that is helpful to everybody. Like everybody can be able to access services at any given time without the fear of cost, without the fear of transportation, without the fear of the resources. Yeah.
Ezekiel, we'll close with you.
Wow. Let me begin by agreeing with what Dr. Torres said, that there are some gains, no matter how small. But what disturbs me is, before I even think of electing a leader, are they leaders or they're politicians?
They're politicians.
Yeah, they're politicians in leadership positions. I would want to engage them, and I'd like to ask somebody, what would you expect if you were to fall sick either with cancer? Why I'm saying this is because, permit me to say, this disturbs me. Yeah. The year I was going through cancer treatment, the same year we had two ministries that were looking after the health portfolio and medical. The two cabinet ministers both had cancer. Without mentioning their names, they both had cancer. But they took, I guess they must have traveled first class to go to the best hospitals in the world. If they could not do something about cancer. In fact, I watched the following year, I saw the budget that was placed for cancer was only 300 million. Is it 300 million? Well, it was not enough to buy one radiotherapy machine. So I want to engage them to, on a personal level, what would you expect? So that now they put what we call, put yourself in the customer's shoes before you give me a promise. That's what I would want to, because anything else becomes the usual promise. And you've seen the viral videos of, in 6 months we shall have this study. You've seen those kind of things. That's what we will still get.
All right.
That's my concern.
Fantastic. Thank you so much,
And
Doris.
maybe just to also add something, in our country, when it comes even to budget allocations, we are still behind with the commitment, the Kenyan commitments that they made in the Abuja Declaration.
exactly.
Yeah.
Should be
I think
15%.
yes.
Right.
So, and we are still lagging behind. We are not even at 10, I guess. So I think it's high time that they put that into consideration.
Certainly. Thank you so much. We're out of time, but thank you for coming, Daktari, Doris, and Ezekiel. Just starting the conversation on what we need to look out for when it comes to healthcare in this country. That's the Voters Hub. We take a short break. We'll be back with much more. Keep the conversation going. #Citizen Weekend and #Voters Hub on social media. We'll be right back.